Welcome, everybody, to this session titled New Diagnostic and Management Guidelines, Putting Them into Clinical Practice is what the session is all about. With me, we are privileged to have three distinguished speakers. None of them need any introductions. They're all known to the field as well to most of you. We will start out the meeting or the speaking sessions with Chris Ryerson, who is the Associate Professor of University of British Columbia and Director of the St. Paul's Hospital Interstitial Lung Disease Clinical and Research Program. And he'll be talking about the IPF guidelines and how to put that into clinical practice. Following which is Dr. Kerri Johannson, who is from University of Calgary, who is the Clinical Associate Professor of Medicine and Community Health Sciences. She will tackle the guidelines for the hypersensitivity pneumonias and how to put that into perspectives in clinical practice. Followed by that is we're very happy and pleased to have Dr. Tamera Corte join us from Australia. Thank you for Dr. Tamera Corte specifically because it's about 4 or 5 o'clock early morning there for her. And Tamera Corte is a consultant physician at the Royal Prince Alfred Hospital at the University of Sydney, Australia. So this will go on from now. Speakers will be speaking one by one, and then we'll get back about an hour from now for a live question and answers. Thank you very much for coming to this session. Enjoy the presentations.
Hello, everyone. Thank you to the organizers for the invitation to speak to you all today. My name is Chris Ryerson. I come to you from Vancouver, Canada at the University of British Columbia. And I'm happy to present on idiopathic pulmonary fibrosis, new diagnostic and management guidelines. A few disclosures, some of which are relevant to this talk. So I'm going to start with a brief recent history of ILD classification. And this really starts in the year 2000. At that time, the ATS-ERS guideline on the diagnosis and management of IPF was produced. And at this time, IPF was defined as a specific form of chronic fibrosing interstitial pneumonia limited to the lung and associated with the histologic appearance of UIP on surgical lung biopsy. There were major and minor criteria for the diagnosis of IPF that were published at that time, as you see here. You had to have all of the major criteria and then 3 out of the 4 or 4 out of the 4 minor criteria. And things have evolved quite significantly since that time. In 2002, the ATS-ERS consensus statement on idiopathic interstitial pneumonia classification was produced. At this time, there was a bit of a backing off of the utility of bronchoalveolar lavage and transbronchial biopsy in fibrotic ILD. And idiopathic NSIP was considered a provisional diagnosis at that time. And there was this nice flow diagram that I think most of you will be familiar with. In 2008, there was an ATS project on idiopathic NSIP, which was defined as a distinct form of idiopathic interstitial pneumonia, so more robustly defined than the previous document had. Importantly, there was suggestion that you needed a surgical lung biopsy to make this diagnosis. And also importantly, there were only 17 cases with definite idiopathic NSIP that were included in the selected multicentric cohort. In 2008, this very helpful document was also produced by the Fleischner Society, which was a glossary of terms for thoracic imaging. It went through almost 100 different imaging findings and patterns and provided examples of each, focusing especially on chest CT scan. For those of you who look at CT scans, if you've not read this, this is a very worthwhile publication to review. An interesting side bit here, honeycombing was defined in this document as clustered cystic air spaces and was thought to usually be subpleural and characterized by well-defined walls, but wasn't always thought to be subpleural and wasn't always required to be stacked, as people commonly think nowadays. In 2011, the ATS-ERS-JRS-ALAT guideline on the diagnosis and treatment of IPF was produced. And at this point, the definition was slightly changed to define IPF as a specific form of chronic progressive fibrosing interstitial pneumonia of unknown cause occurring primarily in older adults, limited to the lungs and associated with a histologic and/or radiologic pattern of UIP. And this was the dreaded table 6 that was produced in that document, which is a little bit tough to apply in clinical practice sometimes. really requires a lot of going back and forth to this document for reference. But essentially what this required was exclusion of other ILDs, and then a UIP pattern on CT scan, or a combination of CT and biopsy findings as shown here to come up with either a confident diagnosis of IPF, a probable diagnosis, a possible diagnosis, or something other than IPF. In 2015, there was an updated guideline focusing on the management of IPF, given some of the recent clinical trial data. These were the pirfenidone and nintedanib studies. And following this, there was a conditional recommendation for the use of either of these medications in mild to moderate IPF. So that brings us to the present state and why we needed new guidelines. And I'm going to go through 3 different reasons for this. So number 1, surgical lung biopsy is risky. Number 2, there were evolving approaches to ILD diagnosis, and I'll go through a few of these. And there are also some new tests that may have clinical relevance. So first, surgical lung biopsy is risky. This is a well-known study from the American Journal of Respiratory and Critical Care Medicine. There was another similar study from the European Respiratory Journal showing the risk of in-hospital mortality after surgical lung biopsy for the diagnosis of ILD. And you can see here, the average in-hospital mortality was about 5% at the end of this observation period. If you split this up into elective and non-elective, even the elective cases, there was still a 1.7% risk of in-hospital mortality following surgical lung biopsy. So these were people who were being referred for a biopsy, admitted as patients, and then undergoing a biopsy during that stay. So a 1.7% risk of mortality is very, very significant, of course. This was an accompanying editorial, which I like to point out. This was a very nicely done editorial that showed that 1/3 of previous studies on this topic reported actually no mortality. And then there were some on the other end of the spectrum that reported very substantial risk of mortality. So what this showed in elective biopsies is that you can do biopsies safely if you're careful about patient selection. So my general rules are that I avoid doing a lung biopsy for patients with ILD if they're over 75, if they're on oxygen, if their DLCO is less than 50%, and this threshold has increased over time for me at least, and I think for some others as well. If there's pulmonary hypertension, a high BMI or a very low BMI, and significant other comorbidities. So if you have any of these things, the risk of biopsy goes up substantially, but if you don't have any of these things, then biopsy is generally safe with careful patient selection. Having said that, we still do want to minimize the need for surgical lung biopsy, which we'll come to in a minute. So there have been some evolving approaches to ILD diagnosis as well. So first, at the top right here, this is a figure taken or a table taken from a study from Simon Walsh a few years ago, showing that we really have poor inter-observer agreement on the diagnosis of idiopathic nonspecific interstitial pneumonia, as well as hypersensitivity pneumonitis. So we need to do a better job, at least at diagnosing those 2 things. There are some potential new diagnoses. As one prominent example, interstitial pneumonia with autoimmune features has been described as a research entity, but has not quite been validated from a clinical perspective yet. Also related to idiopathic NSIP, this ends up being a lot less common, I think, than some people initially believed, especially when you apply a more rigorous definition and criteria to making that diagnosis. So if you require a surgical lung biopsy, as an example in our Canadian registry, only 0.6% of patients end up having a diagnosis of idiopathic NSIP, which is about 10-fold or even 20-fold lower than some other cohorts that have looser definition for idiopathic NSIP. And then finally, we have an improving ability to determine the pretest likelihood of IPF. And if we look across the CT scan spectrum from UIP down to alternative etiologies being suggested, we have a greater ability to pull out some of these patients in the middle range who would have a high likelihood of UIP confirmed by surgical lung biopsy. And specifically those who have a probable UIP pattern, who have moderate to severe ILD, who are male and who are over the age of 60, those patients, even if they have a probable UIP pattern on CT scan, you can make a pretty confident diagnosis of IPF. So these things were not considered too well in the previous guidelines and with some of the justification for the newer document. In terms of new tests, this is one slide from a cryobiopsy study, the Quildice study, showing that cryobiopsy can be used to confidently diagnose ILD, and specifically making a diagnosis of IPF in this case. The main downside of this in this specific study was that cryobiopsy didn't allow you to be quite as confident in your histologic pattern as a surgical lung biopsy would. But if you integrate the biopsy findings with all the other clinical data that the patient comes with, that still allowed you to make a diagnosis of IPF. So you may be a little bit less confident in your histopathologic characterization with the cryobiopsy, but at the end of the day, that lack of confidence in the pathology pattern does not really seem to have clinical relevance. Importantly, there are other studies that have not shown as robust findings of cryobiopsy, so there's a little bit more need for further data on this. There's also the molecular classifier or genomic classifier, which is an algorithm that's applied to pathological tissue that generates a score suggesting whether a patient has a UIP pattern or a non-UIP pattern of fibrosis. This is a study showing essentially that there's relatively poor sensitivity, but good specificity of this score. The clinical utility of this is still a little bit unclear, and this isn't available in all parts of the world at this point, although it is available in the United States. So that background leads us to the new guidelines, which were published 2 years ago now, or 3 years ago now, actually. And I'll talk about two different documents that came out around the same time. One was a white paper from the Fleischner Society, and then the other was the ATS, ERS, JRS, ALAT Clinical Practice Guideline. So starting with the Fleischner Society white paper, the purpose of this document was to provide updated terminology and classification schema for CT and biopsy interpretation for a UIP. This was supported by a systematic review and had several changes from the 2011 guideline approach. A couple of useful parts of this document. First was the practical approach to consideration of the main differential diagnosis. So this is a list of different things to consider as you're evaluating a patient with possible IPF, and sort of a checklist of things for clinicians to think about when they're speaking to that patient. There were 4 radiologic categories proposed at this time, which expanded upon the previous documents that had 3 categories for CT scan. And these include a typical UIP CT scan pattern, probable UIP, indeterminate for UIP, and then features most consistent with a non-IPF diagnosis. Similar things were proposed for pathology with 4 different categories of pathology features. Importantly, this document started to distinguish the UIP pattern that you see in IPF from other causes of a UIP pattern, such as a connective tissue disease or hypersensitivity pneumonitis and others. And this is an evolving and increasingly important concept to understand. There are a few key messages from this document. I'm going to highlight 2 of them. First, it supported a diagnosis of IPF in some patients who had a probable UIP pattern on CT scan, and also further accentuated the importance of a working diagnosis of IPF that could be made after a careful multidisciplinary evaluation of all available data. And essentially, both of these statements increase the percentage of patients who can be assigned a non-invasive diagnosis of IPF and then can be managed as such. So moving on to the clinical practice guideline. So this was a large document intended to help clinicians make an accurate diagnosis of IPF and implement recommended courses of action in the context of individual patient values and preferences. There were recommendations on CT scan specifications, which are quite helpful if your radiology department is still doing CT scans according to the old way, as well as surgical lung biopsy technique. And again, restructured approaches to classification of CT and biopsy patterns of UIP, and then recommendations on when to perform what tests. So looking through the CT scan patterns, so this is a nice figure showing a typical UIP pattern with lower lung predominance, peripheral honeycombing, traction bronchiectasis, some reticulation, without any of these other features that you would see on the right-hand column. So that's a typical UIP pattern. Probable UIP is essentially the same thing, but without the presence of honeycombing. And in some situations, you can have mild ground glass, as you have some suggestion of in this area of this CT scan. Indeterminate for UIP is essentially subtle findings that don't really allow you to make a confident conclusion in one direction or the other. So these are truly indeterminate CT scans. You might have subtle reticulation, you may have subtle or mild ground glass, things like that. And then the alternative category has features that really suggest a different diagnosis. So an example here, this is mosaic attenuation, which is quite marked on this inspiratory CT scan. When you do an expiratory CT scan, there's some air trapping, and there's some ground glass mixed in here as well, the so-called 3-density sign. So these would be findings that would suggest an alternative cause to IPF. There were biopsy categories as well that were nicely laid out. So this is an example of a typical UIP pattern on histopathology with dense fibrosis, a subpleural distribution, some patchy involvement, presence of fibroblastic foci, and then the absence of features that you would see over on this alternative diagnosis category. There were 8 clinically relevant questions on diagnostic decisions that came with recommendations. There was a lot of debate about this, about the exact wording and details of these questions. Each question was supported by a comprehensive systematic review and, if possible, a meta-analysis. And to have a direction of recommendation provided, there needed to be 70% agreement in that direction. And the recommendations were phrased as either we recommend or we suggest, depending on whether it was a strong recommendation or a weak recommendation, either for or against that course of action. So to summarize all of these votes, there were 2 questions that were considered motherhood statements. So these were things that didn't have any evidence synthesis. It was thought that there is no reasonable alternative to taking a history and measuring autoimmune serologies. The next 4 questions were the subject of a little bit more discussion and debate in this document, and really split up into whether it's UIP or a non-UIP category. Sorry, this slide advanced without me intending to, so I'm going to start this slide all over again. I'll give a mini countdown. 3, 2, 1. So there were 8 different questions that were posed to the guideline committee. The first 2 of these included what were described as motherhood statements. So it was thought to not be appropriate to consider the alternative to taking a history or measuring autoimmune serologies. The next 4 questions were the subject of a little bit more discussion and debate. These were best to approach in terms of whether you're talking about a patient with a UIP pattern or a non-UIP pattern. So if you have a UIP pattern on CT scan, essentially none of these other tests are required to be performed. If you have a non-UIP pattern, there was general recommendation in favor of doing a BAL as well as a surgical lung biopsy if you don't get an answer from that BAL. These were weak recommendations for doing these tests, with a small minority of people voting against these procedures. For transbronchial biopsy and cryobiopsy, there was no recommendation provided, given that the committee could not come to a consensus on whether to vote for or against these tests. Multidisciplinary discussion was voted for, and serum biomarkers were voted against, with there not really being anything that's clinically available at this time that can inform the diagnosis. So a few points that I'll make here. So number 1 is UIP versus non-UIP. So the guideline committee voted for each of these tests in either a UIP pattern or everything else. So importantly, probable UIP was included with the non-UIP categories here. So there's a wide spectrum of patients who would fall into this non-UIP category for each of these questions. The recommendation for BAL was different from the 2011 document, and this reflects some evolving practice, although without a huge amount of new evidence. For surgical lung biopsy, this wasn't really actually formally addressed in 2011, so this was a new recommendation in these 2 categories of UIP and non-UIP. Transbronchial biopsy was recommended against when a single recommendation was provided in 2011. In the non-UIP category now, this was a subject of no recommendation given the discordance in the guideline committee voting members. And then for cryobiopsy, this wasn't addressed at all in 2011, as this is a new technique. In the non-UIP category, there was again uncertainty or disagreement amongst the committee members. So no recommendation was provided because we didn't reach that 70% threshold. Importantly, the cryobiopsy vote here happened before the cold ice study that I'd already mentioned. So I'm going to focus a little bit on the surgical lung biopsy question here. So to break this down a little bit, this was the question that was posed and the recommendation that was provided for the use of surgical lung biopsy. So I'll read that out briefly. So for patients with newly detected ILD of unknown cause who are clinically suspected of having IPF and have a CT pattern of probable UIP, indeterminate for UIP, or suggesting an alternative diagnosis, we suggest a surgical lung biopsy. And the vote for that was 17 people in favor and four people against doing that, with these all being weak recommendations for and against. In patients with a UIP pattern, the recommendation was to not perform a surgical lung biopsy, with 2 people voting weakly in favor, 1 weakly against, and 18 strongly against. The thought being that you do not need a surgical lung biopsy in this case to make a diagnosis of IPF. The approach that I take is a little bit different from this, and I think we've got more evidence now to support this being the approach that we should be using currently. So if you have an indeterminate CT scan pattern or an alternative pattern and you don't have an underlying etiology for that, it's reasonable to perform a surgical lung biopsy in this kind of situation. If you have a UIP pattern, again, do not perform a surgical lung biopsy because that's already been diagnosed as IPF. If you have a probable UIP pattern, it depends a little bit on the clinical situation. If you have a man over the age of 60, you probably should not be performing a surgical lung biopsy because that's highly likely to be a diagnosis of IPF. If you have a younger woman, as an example, that might be a situation where a surgical lung biopsy would be more appropriate to consider. So these votes ended up supporting the generation of this algorithm, which is an important algorithm for people practicing in this area to consider for each patient. So a few key points. This algorithm applies to patients with suspected IPF. CT scan has a very central role here. Transbronchial biopsy and cryobiopsy didn't factor into this, although I think cryobiopsy could be added as an alternative to surgical lung biopsy at this point here now. Surgical lung biopsy was favored over BAL. So there's a solid line going down to surgical lung biopsy and a dashed line going down to BAL, suggesting that surgical lung biopsy is a little bit favored. And the multidisciplinary discussion should be considered both before proceeding with invasive tests, as well as after you've got these tests performed. So MDD is a central component of this diagnostic process. And this then led to this integrated table. So this table has now become figure 8 of the new guidelines that show the intersection or the integration between the CT scan patterns and the histopathology patterns. So this is a busy table and something that you're not likely to remember, but a few key take-home points. So first, if you have a CT scan pattern of UIP, you don't need a biopsy to make a diagnosis of IPF. If you have a probable CT scan pattern for UIP, you may not need to biopsy, and specifically if you're over 60 and a male and have more than mild disease, you don't need a biopsy to confirm a diagnosis of IPF. If you have an indeterminate for UIP pattern or a pattern suggesting an alternative diagnosis without an alternative diagnosis already being identified, then you do need a biopsy to make an IPF diagnosis, but again, with some caution about the safety of that procedure in some situations. A few limitations and gaps that are worth mentioning. So again, stratified recommendations by UIP versus not UIP. I think now the evidence would suggest that we probably should be categorizing as UIP/probable UIP versus the remainder. And it's more likely that we're not going to be biopsying probable UIP as much in the future. I think there is still limited evidence that BAL is useful in distinguishing IPF from the typical differential diagnosis. So things like eosinophilic pneumonias, sarcoidosis, infection, those are helpful things for a BAL, but those are not often on the radiographic differential diagnosis for IPF. The guideline committee was unable to come to a consensus for cryobiopsy and transbronchial biopsy, although I suspect that for cryobiopsy that would be possible now. And we did not address the genetic testing and the utility of molecular classifier. So a few take-home points to conclude. So first, IPF is often difficult to diagnose. HP is the main differential diagnosis, which I think will be spoken about shortly. There are several clinical factors that increase the likelihood of IPF, and specifically, again, older age, male sex, and increasing ILD severity. There may be a role for BAL and cryobiopsy in non-UIP fibrotic ILD, but both of these are variably used and recommended at present. So we do have guidelines. These have some limitations, as I've mentioned, the weak underlying evidence, the simplicity and implementation is often prioritized over comprehensiveness. So it's difficult to meet all the different needs across the varying levels of expertise. And it's a long process to develop these guidelines. There are some differences in the Fleischner and the ATS, ERS, JRS, ALAT documents, but these really are minor and largely reflect either nuances or differences in the document types and intended audience. And there are some further updated guidelines that are coming. So with that, I'll stop and say thank you and happy to answer questions when the session is complete. Thank you.
Hello, I'm Kerri Johannson, and I will be speaking with you today about hypersensitivity pneumonitis, update on diagnosis and management. So this is really going to focus on diagnosis, given the recent guidelines that have been published. I'm hoping I will be able to integrate them, highlight some similarities across them, some discrepancies, and hopefully have some takeaway points that you can use in clinical practice. These are my disclosures. So historically, there has been abysmal agreement on what hypersensitivity pneumonitis is. If you've ever tried to publish a paper on HP, you will know that. Nobody could previously agree that the patients you were talking about actually had HP. This study by Simon Walsh and team looked at multidisciplinary team agreement across different diagnoses and found that for IPF, the agreement was pretty good. Connective tissue disease related ILD also good. NSIP, not bad, but really quite abysmal for HP. And this is where we found ourselves up to this point. And yet we've been blessed in the last year and a half with a veritable cornucopia of guidelines. So this, the ATS, JRS, ALAT clinical practice guideline on hypersensitivity pneumonitis, I'll probably refer to it as the ATS guideline moving forward for simplicity, published in 2020. And this guideline from the American College of Chest Physicians, which I'll just be referring to as the CHEST guideline. Both of them provide really important information on how to diagnose HP in adults. The ATS guideline reviewed 6 PICO questions, whereas the CHEST guideline reviewed 14 PICO questions, and I'll try to synthesize them here moving forward. So the one thing that is consistent between both of these guidelines, and is really a big step moving forward, is a new HP classification. And this study is just one of many examples demonstrating that patients with fibrosis with HP do worse than patients who do not have fibrosis. This is an important differentiation for treatment, for prognostication and outcomes. So what is out moving forward is acute, subacute, and chronic HP. What is in moving forward is non-fibrotic and fibrotic HP. And the fibrosis doesn't need to be necessarily on a biopsy because many patients won't have that, but the fibrosis can be evident on chest imaging, so HRCT scan. So the approach to HP diagnosis, I'm going to run through some of these major categories and the major steps, and I'm going to focus on exposure assessment with history, questionnaires, serum-specific immunoglobulins. And the reason I think it's important to focus on this is that whether there is an identified antigen or a compelling antigen exposure is the branch point for many diagnostic algorithms for HP. I'll also talk about bronchoscopy, HRCT scan, lung biopsy, multidisciplinary discussion, and a little bit about whether or not a treatment trial can be informative. So exposure assessment tools for HP. So both guidelines agree that we should all be taking a thorough history when evaluating our patients with HP. So a history looking for known exposures associated with HP. Is there a time relationships, the exposure occurred before disease? Is there some possibility that if the exposure was removed, did they have some sort of clinical improvement? So this is really important. And both agreed that a questionnaire would be great, but there really isn't one. There isn't a validated questionnaire that can perform well across different regions to ensure that we are identifying the majority of patients with HP and their exposures. This exposure questionnaire developed by Haley Barnes and her team is published online in CHEST. It's not validated yet, but hopefully will be. And another resource I wanted to highlight was hplung.com, which was inspired by Pneumotox to identify all of the published reports of HP in the literature. So it's a free online website. You can go and look for potential exposures that may be impacting your patient. So this is an area for future development. It was highlighted in the CHEST guideline that if patients are suspected of having occupational HP, You should involve an industrial hygienist or occupational medicine if you have access to those resources. And that we should be classifying patients based on their inciting antigen status. So in the ATS guideline, it's broken down into identified or not identified. In the CHEST guideline, it's a little bit more nuanced into identified, indeterminate, which is probably where a lot of our exposure identification falls. A little bit of mold down to low, is that enough to say it's identified or not? And then unidentified, and that gives a little bit more nuance and granularity. Things that were agreed upon in both guidelines were not to use inhalational challenge testing, don't do lymphocyte proliferation testing, and relying on an improvement with antigen avoidance might be helpful in some cases of non-fibrotic HP, but is unlikely to be informative or to really solidify a diagnosis, particularly in fibrotic HP. So it might be a little bit helpful, but certainly don't rely on it. Serum-specific immunoglobulins is a bit more of a controversial recommendation from both. So the ATS guideline suggests performing IgG testing in patients with suspected HP. It's a suggestion with very low confidence in the effect estimates. The CHEST guideline relying solely on IgG or IgA testing. So again, that was a weak recommendation with very low quality of evidence. So in summary, the evidence is poor that serum-specific immunoglobulin testing adds any discriminative value. When you really go through the studies, it's not super helpful. The assays and interpretation of what constitutes a positive test versus a negative test is not standardized, and you really see that when you go through the literature. However, personalized testing holds promise. So if you go into a patient's environment, collect samples, and then test their serum against that, that might be a helpful tool moving forward. But again, that's really limited to certain areas. So we published a workshop that was supported by the ATS looking at exposure assessment tools. So if you're interested, I think this goes into a little bit more granular detail about the potential tools of history, questionnaire, improvement with antigen avoidance, environmental assessment, inhalational challenge, immunoglobulins, lymphocyte proliferation testing, and then whether or not you should use a multidisciplinary assessment of clinicians with environmental exposure experts. And our 20 panelists rated these on how well these perform, whether they're feasible or not, and their overall clinical utility. And so this concept really extends from the ACCP categorization of inciting antigen, whether it's identified, indeterminate, or unidentified. And I think you can think about it really establishing your pretest probability of HP. If there's no exposure, you're starting at a lower pretest probability of disease. So your post-test probability is going to be lower, even for the same CT scan, bronchoscopy, other variables that you might incorporate in your diagnostic algorithm. And with a highly convincing exposure, you're starting from a higher pretest probability. So I'm really thinking about these along a spectrum of where we start from a pretest probability of disease at the very beginning of the clinical evaluation, with heavy weight placed on exposure identification and antigen identification. So BAL cellular analysis was also a little bit of different recommendations between the two guidelines. Should we be looking at lymphocyte count, essentially? So the ATS guideline recommends doing it for non-fibrotic HP and suggests doing it for fibrotic HP. For non-fibrotic HP, it might be more informative if you've got infection, like tuberculosis, malignancy, other things on the differential diagnosis, and it's relatively safe and non-invasive, less likely to be helpful for fibrotic HP. And in the ATS guideline, they proposed a cutoff of greater than 30%. So really thinking of it as kind of a binary. Above 30%, that's more likely to be HP if you identify a lymphocytosis. The CHEST guideline recommends not routinely doing BAL to confirm a diagnosis. So that's quite interesting, and I'll take you through the algorithm and show where that comes up in your sort of diagnostic pathway and clinical thinking. It can be supportive, but it's not diagnostic of HP. And notably in the CHEST guideline, no percent cutoff was proposed, realizing that a lower percentage is going to have higher sensitivity but less specificity, and you trade that off if you're using a higher threshold. So if you're using a 40% cutoff, it might be more specific for HP, but you're going to lose some sensitivity in some patients. The takeaway point here is the absence of a BAL lymphocytosis doesn't rule out HP, and the presence of a lymphocytosis is not diagnostic. again, being supportive, but needs to be taken into consideration with all other variables. So a major advance, I think, in both of these guidelines is the definition, or sort of the characterization of patterns, hypersensitivity pneumonitis patterns that would be typical, compatible, or indeterminate. And there's a lot of overlap between both the ATS and the CHEST guidelines of how these are characterized. So they're broken down into non-fibrotic patterns and fibrotic patterns, which I'll show you in a second. So a typical HP CT scan would be examples of this. So central lobular nodules, possibly with some areas of ground glass. And these areas of the 3 density sign, so areas of ground glass attenuation, normal lung, and lobules with hypoattenuation that can correspond to air trapping on dynamic expiratory imaging. Something that would be compatible with HP would be areas of random ground glass with some cystic change. Interestingly, there is nothing in non-fibrotic HP that is considered indeterminate. For a typical HP in fibrotic pattern would be examples here. So areas of fibrosis that are often diffuse in axial or craniocaudal distribution, with areas of hypoattenuation, and again showing this 3 density sign. So there are areas of reticulation, but there is ground glass attenuation, normal lung, and hypoattenuation that again corresponds to gas trapping on expiratory imaging. CT patterns that can be compatible with HP would be, you can have extensive fibrosis in a mid to upper lung predominance. The fibrosis can be extending centrally or peribronchovascular distribution, and then again having these areas of hypoattenuation. And a key thing that changed in both of these guidelines, the sign that was formerly known as head cheese. I think we're moving away from food categorizations, partly because they're gross and because they can be better described using radiographic findings. So the 3 density pattern involves lung lobules with preserved density surrounded by patchy areas of ground glass attenuation. These are interspersed with lobules of decreased density and decreased vessel size occurring within the same lobe. And this has been shown in previous work to be very specific for hypersensitivity pneumonitis. So lung biopsy, the ATS guideline broke this down as to what type of biopsy should you do, whereas the CHEST guideline in the PICO question was really focused on how to integrate the lung biopsy and when should you pursue it, not necessarily ranking which one is better over the others. So transbronchial biopsy is suggested for non-fibrotic HP. It might be helpful, again, depending on what's the differential diagnosis. So if there's infection or sarcoidosis or malignancy, transbronchial biopsy is relatively safe and fairly easily accessible at most centers. So a weak suggestion to do it if you think it'll be helpful. Transbronchial cryobiopsy was suggested for fibrotic HP with no recommendation for non-fibrotic HP. And surgical lung biopsy in both of the guidelines is suggested, with the key being if histopathologic data are needed after the patient has been reviewed in a multidisciplinary discussion. So certainly every patient shouldn't be undergoing this, and it should only be done if that's in keeping with the patient's values and preferences, and if it's really needed, not only to establish a diagnosis, but to dictate care and hopefully improve patient outcomes. With classic histopathologic features being cellular or fibrosing interstitial pneumonia, cellular bronchiolitis or airway-centric fibrosis, poorly formed non-necrotizing granulomas, and then absent features suggesting alternatives. So things that don't suggest CTD, sarcoid, or aspiration. So bringing all of this together, should patients be reviewed in multidisciplinary discussion? Absolutely. So MDD is a key feature of both of these diagnostic algorithms. So this is an algorithm from the ATS guideline, and this is from the CHEST guideline. Multidisciplinary discussion comes up at multiple points and should be, patients should be reviewed in the MDD before getting sent for lung biopsy to ensure that it's actually needed. And then once it's done, the biopsy should, and the rest of the clinical information should again be reviewed in the MDD. So the diagnostic algorithms, this is the ATS diagnostic algorithm, and this is the CHEST diagnostic algorithm. And again, reiterating that these algorithms and these guidelines, you don't need to follow these to a T. These are here to provide information that help with a probability of disease and a degree of confidence, and are hopefully helpful tools in clinical practice. practice. So I'm going to run through some cases and show how both of these perform in different clinical contexts. So case example number one, let's say we have a patient who has a pet cockatiel and a pet parrot. One of those patients, when you're phoning them, you can hear the birds squawking in the background. There is no doubt that they have an exposure, a confirmed exposure consistent with HP. In the ATS guideline, we start actually from the CT perspective. So let's say they've got a typical CT for HP with mosaic attenuation, central lobular nodules, and they have a clear exposure. If you choose not to do a bronchoscopy or a biopsy, the highest degree of confidence you can get here would be a moderate confidence diagnosis of HP. To get a high confidence diagnosis, you would have to have the CT, the exposure, and a BAL lymphocytosis. No need for a biopsy to get high confidence. But to make a definite diagnosis, in this algorithm, you cannot establish what is considered a definite diagnosis without histopathology. So quite interestingly, in the chest guideline, that starts at the top with inciting antigen exposure. So they've got birds, it's identified. They have a typical HP-CT. HP can be diagnosed here with greater than 90% confidence. And so I think that this confidence degree in the high provisional confidence diagnoses or the definite diagnoses is where the two guidelines actually perform quite differently. In a second example, say the patient has some mold at home. It's not like an overt mold exposure, but you're not sure if this actually is anything meaningful. In the ATS guideline, that would be considered exposure negative. So even if they have a typical for HP CT scan, the exposure is negative, you take them to bronchoscopy and there's BAL lymphocytes of 32%, you can establish a moderate confidence diagnosis of HP. Whereas in using the chest guideline, here it would be considered a somewhat indeterminate. It's possibly there, it's definitely in the environment. You have no idea if it's causal. If they have a typical CT and a BAL lymphocytosis, that is considered a provisional high confidence diagnosis of HP. So notably here, the diagnostic confidence, so that would put them in the 70 to 89% category. Case example 3, let's say they have no exposure, an indeterminate CT with some fibrosis takes you down this pathway. You do a BAL, there's no lymphocytosis, HP is not excluded. And I think that brings up the point that HP is challenging. It can really take on many different forms. It's probably not going to be HP, but it really depends what's on your differential diagnosis in this clinical scenario, but it's not excluded. And similarly, in the chest guideline, the antigen here, unidentified, an indeterminate CT for HP, no lymphocytosis, takes you down this pathway of it being unlikely. So less than 50%, this is HP. And again, that final diagnosis depends what's on your differential diagnosis. So based on recognizing that these guidelines can lead you to different degrees of diagnostic confidence, this study took 144 very well characterized patients with HP and applied the ATS algorithm and the chest algorithm to all of these patients. And what they found was that using the ATS criteria, only 18% of patients could be diagnosed with definite HP, and all these patients had undergone surgical lung biopsy. But 42 and 34% were diagnosed with high or moderate confidence diagnosis, leading to 94% of these patients having a diagnosis of HP with 70% confidence or above. Using the chest algorithm, 65% of patients received a confident diagnosis of HP. So that's quite different, 65 versus 18%. And another 20% had a high confidence diagnosis. So again, that led to 92% of these patients getting diagnosed with HP with 70% confidence or greater. I think what this really highlights is how much do we need to be splitting hairs on degrees of confidence. And I think we need to address as a field whether or not a 70% confidence or greater is adequate for HP, because that seems to be where the both guidelines really overlap and have very high agreement. So the management of HP, not much has changed a little bit, but this is just one example of a clinical algorithm for sort of practical take-home points. The first approach is comprehensive antigen remediation if it's able to be identified. That is a must. We are also using corticosteroids for patients who have either severe presentation at diagnosis or who have a combination of inflammatory and fibrotic disease. If they can't be tapered or they have significant chronic or fibrotic HP, we're using steroid-sparing agents with mycophenolate or azathioprine. And in patients who progress despite this, we can now be considering antifibrotic therapies if they have a progressive fibrotic phenotype, so the fibrosis is getting worse despite usual management, remembering to refer to lung transplant, use oxygen, pulmonary rehab, potentially advanced immunosuppressive therapies, and enrolling in clinical trials. Another area being the treatment of HP that requires a lot of further study. So from the diagnostic perspective, these are the key takeaway points of the definitely do's and things to consider in specific circumstances that I hope will be helpful in establishing a diagnosis of HP in your patients. I'd like to thank you for your time, and I look forward to questions in the live session.
So hello, my name is Tamera Corte, and I just want to say thank you very much to the Pulmonary Fibrosis Foundation organisers for inviting me to give this talk today. I'm from Royal Prince Alfred Hospital in Sydney, Australia, and I'm going to talk today on connective tissue disease associated interstitial lung disease and give you a little update on both the diagnosis and management of this condition. So they're my personal and institutional disclosures. So when I talk about interstitial lung disease associated with connective tissue disease, I really like to put it firstly in the broad classification of interstitial lung disease. So the connective tissue disease associated interstitial lung diseases are in the group of the known association. So we have interstitial lung disease, which is idiopathic, and then interstitial lung disease of known association. And you can see that there are really a number of different, almost all connective tissue diseases can be associated with an interstitial lung disease. And something which is not on this classification is that sometimes we have patients who don't actually fit a particular connective tissue disease, but who have features of a connective tissue disease. And those patients often cause some problems with regard to diagnosis, as they don't fit that exact classification. And what I wanted to point out is that it's not always a clear-cut case. So in fact, we often see an overlap between idiopathic interstitial lung disease or idiopathic interstitial pneumonia and connective tissue disease associated ILD. For example, as seen here, we can have a patient with a usual interstitial pneumonia pattern, both on radiology and histopathology. And this could in fact be a patient with idiopathic pulmonary fibrosis, but equally it could be a patient with rheumatoid arthritis or systemic sclerosis, for example. And I just want to make that point because it's sometimes very difficult to distinguish between the two. So we also have patients with a non-specific interstitial pneumonia pattern, for example, who may well in fact have idiopathic disease or in fact have underlying systemic sclerosis. The same goes for organizing pneumonia or fibrosing organizing pneumonia, which can be idiopathic or cryptogenic in COP, but equally could be associated with one of the inflammatory myopathies. And again, with lymphocytic interstitial pneumonia, it can be idiopathic, but equally could be associated more classically with Sjogren's syndrome. So why is it important to distinguish between idiopathic disease and when there is an underlying connective tissue disease? Well, firstly, it's becoming increasingly more commonly recognised. So the prevalence studies range from somewhere between 45 to 75% for scleroderma, 30 to 60% for rheumatoid arthritis, and 30 to 50% for the inflammatory myopathies, depending on how it's defined and how it's looked for. But also in each of these conditions, having interstitial lung disease is associated with significant increase in both morbidity and mortality. And why do we want to distinguish whether there is an underlying connective tissue disease? Because it has quite significant implications both for treatment and for prognosis. So with regard to treatment, more classically, connective tissue disease associated ILD is usually treated with first-line immunosuppression. And certainly with regard to prognosis, those patients generally with connective tissue disease tend to do better than those patients with idiopathic disease. Now, that's very much a broad brush overview. There's certainly individual differences in that I've just really summarized the approach there. But of course, having an underlying connective tissue disease would affect your initial approach to a patient. And so moving towards our patient example, I've just got one case here to make a point both with regard to diagnosis and management. So this is Mrs. Casey, a 68-year-old female with who presented with breathlessness and cough. She didn't know she had a connective tissue disease, but on close questioning, she actually had a long-standing history of Raynaud's phenomenon, and in fact had developed sicker symptoms, so dry eyes, dry mouth, over the last few years. We do a serology screen on all our interstitial lung disease new patients, and quite surprisingly for her, she had a strongly positive SCL70, an ANA 1 in 640 and a Rho 52, which is positive. She had the CT scan, which I've taken a photo of here for you, which showed a fibrotic non-specific interstitial pneumonia pattern. So this is a lady who doesn't have a connective tissue disease, doesn't particularly fit any of the criteria for a specific connective tissue disease. And we'll talk a little bit about what this means, but just suffice to say that we managed her as if she had connective tissue disease associated interstitial lung disease. So how do we approach diagnosing connective tissue disease associated ILD? Well, when we know someone's got a connective tissue disease, then that's easy, isn't it? So if someone presents with systemic sclerosis or rheumatoid arthritis, then what do we do? Well, firstly, we confirm the connective tissue disease diagnosis and then consider whether the interstitial lung disease pattern is consistent. Of course, there are always alternative etiologies to consider. So, for example, is the patient on methotrexate or other drugs which might be contributing to the interstitial lung disease, or do they smoke? Is there a nosocomial infection? Is the patient on immunosuppression? But then we make a treatment decision, which is largely based on the duration of the connective tissue disease diagnosis, how severe it is, and how quickly the interstitial lung disease is progressing. But when there's no underlying connective tissue disease, that's where it gets a little bit more complicated. So that's where a detailed assessment and reassessment might reveal an underlying hidden connective tissue disease. So a multidisciplinary approach with a rheumatologist is important, with obviously history and examination, but also serology, and sometimes now fold capillaroscopy as well. So who do we worry about? Particularly women who are younger than 50. And there are a number of other features which I'll talk about, which might be a flag for underlying connective tissue disease. Some of the clinical features I've photographed here include Raynaud's phenomenon or sclerodactyly, skin changes associated often with the inflammatory myopathies, or like my patient had sicker symptoms. With regard to autoantibody testing, in our site, we do a comprehensive panel including myositis antibodies, but there have been suggestions for a two-pronged approach with a set of core tests which are performed in all new patients for interstitial lung disease, looking for an underlying connective tissue disease, and then with a second group of the myositis-associated antibodies and the myositis-specific antibodies to be studied in those people with a high pretest probability for connective tissue disease. And that obviously depends on availability and in insurance, etc. But as I say, we're very fortunate to be able to do that in all of our patients. And how do we do that? Well, there's the Uroline blot test, which can be performed. And where this one, there are a number of choices, but this one looks at 16 antigen. And I guess the point I wanted to make is the more that one looks at these tests in patients with otherwise idiopathic disease, the more one gets positive results. And it's hard to know exactly what to do with those results in a patient who doesn't have any connective tissue disease symptoms. And I know in some places in the world, but also here in Sydney, we would go on to do immunoprecipitation to confirm that result. And this is where we precipitate a protein using an antibody which specifically binds to that protein. I guess this is certainly a different test. I don't know that there's a lot of evidence that it's particularly better, but it certainly has a different specificity and sensitivity than the Uroline blot test. And I like this quote at the bottom here, which says the high prevalence of multiple positives and the discordant rate of antibodies could create misinterpretation of the results from a clinical point of view. I think that just summarizes the fact that we don't really know what to do with these results sometimes in the idiopathic, otherwise idiopathic patient. So what don't we know? We don't know which test to perform in which patients or how often to repeat the testing. Certainly if you do repeat them, a significant proportion of patients will become seropositive over time or seronegative. And what the implications for the positive tests are in an otherwise idiopathic patient. Certainly we know there are radiological clues to having underlying connective tissue disease. So a combination of patterns, particularly an overlap of non-specific interstitial pneumonia, organizing pneumonia is a clue to have that the patient might have an underlying connective tissue disease, and having extra parenchymal features that I've photographed here for you. So airway disease, pleural disease, evidence of pulmonary hypertension or esophageal abnormalities. These are all clues for underlying connective tissue disease. But even with the best intentions, it's not always straightforward, and this is where the research classification for interstitial pneumonia with autoimmune features comes into play. And this is those patients, such as my case, with an interstitial lung disease without a clear a diagnosis of connective tissue disease, who have no other identifiable etiology, and who satisfy 2 of 3 domains: the clinical domain, serological domain, or the morphological domain. So moving on, what's new in this field? Well, there are 2 things I just want to add to the sort of classical approach, and one of them is the increasing role for nail fold capillaroscopy. It's where we use a magnifying lens to look at the nail bed circulation. It's by no means a new test, but there's some recent modification. So it's now available to be done on your smartphone, which makes it easier to perform in the ILD or the rheumatology clinic. And we now it's now included in the classification for scleroderma. And what do we know? Well, we know that there are some patients with idiopathic disease who do have non-specific nail fold capillaroscopy abnormalities. And there's some work to be determined as to whether or not there is a screening role for this in otherwise idiopathic disease. The other thing I'll just touch on is the immense amount of work in the literature about different biomarkers. And there's no possibility of covering all of this in one single talk, but suffice to say that there are a number of different pathways and exciting progress with regard to biomarkers, which have been shown to be useful in being related to the amount of fibrosis, but also with a potential role for screening in patients with rheumatological disease. So this is a suggested algorithm. I guess the principles there are to thoroughly assess and reassess in a multidisciplinary setting, and then to consider some of these new possibilities as they become more validated in the future. So moving on to the management of connective tissue disease associated ILD, we'll go back to the case. So this is my case. What do we do with her? Well, as I said, we managed her as if she had connective tissue disease, although she fits the IPAF criteria. So she's now been stable for 6 years on mycophenolate 1 gram BD and prednisone 7.5 milligrams daily. When we look at management of connective tissue disease overall, there are a number of different agents which I could talk about. Conventionally, we see the use of corticosteroids and immunosuppression, such as azathioprine, mycophenolate, cyclophosphamide. A number of biological agents, such as rituximab and tocilizumab, have been recently shown to be effective in connective tissue disease-associated ILD. And then there's non-biological agents, including tacrolimus, with increasing evidence in the inflammatory myopathies, as well as imatinib, infliximab, adalimumab, and etanercept. And then, of course, there are a number of other agents, including the antifibrotics, which I'll touch upon today. But I don't want to forget that there's certainly evidence with regard to stem cell transplant in scleroderma, lung transplant, of course, and plasma exchange and immunoglobulins. So I wanted to make this point from this fantastic article which summarised all the clinical trials in connective tissue disease-associated ILD. And really it makes the point that the majority of the trials, the randomised placebo-controlled trials, are in systemic sclerosis. And it makes the other point that, in fact, none of the trials to date have been in rheumatoid arthritis, although that I know certainly there are studies undergoing or about to be published, but in this summary, there's really no trials, randomized trials in rheumatoid arthritis. So with that in mind, we'll just touch on some of the literature. So this scleroderma lung study was the traditional first study, which really looked at oral cyclophosphamide versus placebo, showing a benefit of change in FVC in those patients with systemic sclerosis. And the scleroderma lung study 2 then compared oral cyclophosphamide to mycophenolate and showed equivalence, but the patients on mycophenolate tolerated their agent much better than the oral cyclophosphamide. And this is a 2-year study in systemic sclerosis. And then more recently, the tocilizumab studies, which used skin as a primary endpoint and it was in fact a negative study. But then it, as a secondary endpoint, did show a benefit of tocilizumab over placebo for change in FVC at 48 weeks for patients with and without underlying interstitial lung disease. So just to summarize today, immunosuppressive drugs are still the standard of care for connective tissue disease-associated ILD, acknowledging that the data is mainly extrapolated from the systemic sclerosis literature. But what happens when those drugs fail? And that's where the newer evidence for antifibrotics comes into play. You can see there are a number of studies now which have accumulated for antifibrotics in non-IPF interstitial lung disease. So I'll touch firstly on the census study for systemic sclerosis. And this looked at nintedanib, 150 milligrams BD versus placebo in patients with systemic sclerosis, and looked at the primary endpoint of rate of decline in FVC at 12 months. And it was a positive study showing a relative reduction of 44% in the patients on nintedanib. And in the subgroup analysis, looking at patients who were taking mycophenolate at baseline compared to, and patients who weren't taking mycophenolate baseline, we see the effect across both of those subgroups. So it seems to be an additional effect to background immunosuppression. And then moving to the same drug, so nintedanib, but now in progressive fibrosing interstitial lung disease. So all interstitial lung disease optimally managed with conventional therapy, patients who continue to progress despite optimal treatment. And in that group, which included connective tissue disease-associated ILD, again, nintedanib was shown to have a significant relative reduction of 57% of compared to placebo. And again, that was with the primary endpoint of rate of decline of FVC. And this is shown across the 2 subgroups of whether the patients had a baseline CT with a usual interstitial pneumonia pattern or not. It's the same data there, just showing the nice deviation in the curves. And this is the subgroup analysis I alluded to. So the green portion of the pie chart there is patients with underlying connective tissue disease. And you can see that the effect was seen across the different subgroups of the progressive fibrosing interstitial lung diseases. Moving to pirfenidone, we see in the RELIEF study, which looked at pirfenidone in progressive fibrosing interstitial lung disease, including connective tissue disease-associated ILD, that even though this study had to stop early due to problems with recruitment due to COVID-19, that we do see a clear difference, a benefit with regard to pirfenidone versus placebo in those patients. And similarly with the unclassifiable progressive fibrosing interstitial lung disease study, which had a primary endpoint of home spirometry, which was not met. But in the secondary endpoint of site spirometry, again, we see a difference, a benefit with pirfenidone versus placebo in those patients, which included the idiopathic pneumonia with autoimmune features group. So what is the suggested approach? Well, I like this nice diagram here from Peter George in the Lancet Respiratory Medicine. To summarize, it's that we haven't taken away from the importance of ensuring an accurate diagnosis of connective tissue disease. And the treatment remains with standard of care, which in this case is still immunosuppression. But if the evidence of progression exists despite conventional therapy, to consider antifibrotic therapy in those cases. So what are my take-home messages? Well, the presence of underlying connective tissue disease does matter, and a careful diagnostic assessment and reassessment for connective tissue disease is important. And that's because immunosuppressive therapy does work in some connective tissue disease-associated ILD patients, with acknowledging that there's not a lot of literature, and much of the literature is extrapolated from systemic sclerosis. And then, of course, if there is disease progression despite standard of care, to consider some of these other agents which I mentioned, and in particular to consider antifibrotic therapy. And that, of course, depends on availability. In Australia, we don't have access to antifibrotic therapy at the moment in connective tissue disease, but I know certainly in some countries globally that there is more easy access. So I'd like to acknowledge a few people and just say that I'll be dialing in at the time of the conference for questions. So thank you very much once again.
Well, welcome back, everybody. So I hope you had a nice, enjoyable presentation with our three distinguished speakers who covered the three important topics for clinical practice for IPF, hypersensitivity pneumonitis, and connective tissue disease associated with interstitial lung disease. So this is a question and answer hour. So what we'll take is the question randomly. And the first question, I'll request Dr. Tamera Corte to address the important issue of can you speak to current technical considerations with cryobiopsy? In other words, how do patients provide and know the cryobiopsy will be sufficient sampling? So basically the question is about cryobiopsy sampling adequacy performed. So Tamera, can you address this?
Sure, Ganesh. Thank you for the question. So I think if I could just bring us back to the cold ice data that was published last year or 2019, we know that the cryobiopsy samples have a really high concordance with the surgical lung biopsy. But I'd really take the point of the question is that really that comes down to the fact that we're assuming these cryobiopsy specimens are adequate. And that, I think, it's difficult. I mean, what we know from the cold ice data is that with the number of samples, the adequacy or the agreement increased, and with the sweet spot being at least five biopsy samples. But I think that the question gets to the crux of the matter, really, in that oftentimes when we're doing cryobiopsies, we do one and then there's bleeding, or for some reason we can't go on to do further biopsies. So, look, I think we need revised guidelines that are just focusing on the cryobiopsies for the histopathology, and I think we're some way towards that. But also, there has to be some flexibility in for the proceduralist at the time, because not everyone can have the 5 or more biopsy samples as we might need for optimal agreement. So look, I think it's a really tricky question. Yeah. But hopefully that answers it.
Very much. Yeah, thank you, Tamera, because again, what Tamera alluded to, they did a fantastic, elegant prospective study in Australia called the COLD study, and that study has been published in the Lancet Respiratory Medicine, I believe about 2018 or thereabouts. So that has got all the data on this very specific questions furthermore. The next question is also to you, Tamera, while you're on it. Given the increased availability of antibody testing, example, the myositis panel, what's your opinion on getting a full antibody panel in patients with indeterminate or probable UIP, especially considering that the lungs can be first organ to be involved in a subset of patients with autoimmune lung diseases?
Yeah, I wish I knew the answer to this question, and we were just talking about it in the chat before. Look, in my practice, we do a full antibody screen in everyone, but as we do this more and more, I think that there are many false positives. So I think that it's probably not applicable to do in everybody across the board, but when there's a very high suspicion or there's some clinical indication, or if you're working very closely with a rheumatologist or immunologist who can look closer, for example, do nail file capillaroscopy or other. Or if you have a plan to confirm what you're going to do with that positive result. So I know in some sites, for example, they'll go on to do confirmatory antibody testing. In our site, we'll do nail fold testing, for example. But look, I think it's very difficult if you do it across the board, because you will get a certain proportion of false positive results.
Yeah, no, I think that's a good point. But in my practice, after that guidelines is written, we are doing a complete panel that includes ANC, a panel for what it is. But in doing so, I have created what is called an Ild Panel Test, including an ANC panel, C-reactive protein sedimentation rate. And the ANC panel has actually turned out to be quite interesting. And we have now about 70 or 80 patients who turned out to have an ANC panel. And so that's a newer knowledge in terms of the limited UIP pattern with an ANC panel positivity. So it is always important, I think, to discuss this with the rheumatologist in your group, and then see whether that patient with the asymptomatic antibody testing has any bearing in terms of the clinical criteria based on the American Rheumatological Association criteria to meet the diagnosis of that very specific entity. For example, the anti-synthetase syndrome in the myositis panel, actually, they can be completely asymptomatic and have absolutely no myositis, either by symptoms or so. So I think it's important to discuss that with the rheumatologist and get a multidisciplinary discussions in terms of the specific diagnosis of connective tissue disease. But we're talking about the serology testing. I'd like to move to the hypersensitivity pneumonitis, because this is another important area of a gray zone. Serological testing for HP at many institutions in the United States is limited. Is there an extended hypersensitivity pneumonitis panel that some institutions might be doing and can be done as a send out? Kerri, Johannson, I'm sure you can answer this elegantly.
Yes, so as a Canadian on the panel, it might make it a little challenging to know what panels there are available in the United States. We have very limited access to serologic testing for hypersensitivity pneumonitis panels or serum-specific immunoglobulins in Canada. And I've tried actually in rare occasions to try to have them sent to the National Jewish or to have them sent to the Mayo Clinic. And the paperwork became so prohibitive that at the end of it, we just threw our hands up and said no. And for the most part, recognizing that these panels, that the commercial kits that are available to identify antigens that are associated with mold exposures or hypersensitivity pneumonitis may not overlap with what's actually in people's homes or in their environments. And so I think the reason they're not particularly accessible is largely driven by the fact that people aren't finding them to be very helpful. And I know that lots of people who use these on a regular basis will swear by them and say, we do this on every single ILD patient that comes in, but a large number of centers have no access to them or don't use them in any way because they don't find that it provides additional discriminative value. So I think the availability is limited. I think if you're using pigeon sera from one part of a large continent or a large country, that may differ from the actual proteins that exist in a bird on the other side of the country. So I know there's geographic variation in these proteins as well. So I don't think there's a good answer to that. I'm not aware of one particular kit or send out that would be useful for all.
No, you're absolutely right, because there is no so-called extended panel. Once upon a time in UC San Diego, there was a 23 panel or 23 antigen that they had in their own laboratory, but there is no end to it. But the hypersensitive pneumonitis panel that is available in the commercial kit in certain laboratories out, at least if you do it and if it's positive, you know it is positive, but then you have to utilize that in the context of the clinical situation. So at this moment, unfortunately, there is no validated extended HP panel that some institutes might be doing. And if they do, that's great, but then you need to put it in the context of the clinical situation and discussion. Next question is to, I think this will be useful for Chris to answer. The difference between ATS and ERS and the ACCP guidelines on bronchial lavage is interesting. Do you still find a primary predictor of BALS vote to where you train, North America, East Asia, or Europe? If so, what can we do about this? Chris or Kerri, both of you can answer. Let's start with Chris.
Sure. So it's a good question. So obviously we're talking about the HP guidelines from ATS and the HP guidelines from ACCP primarily.
BAL lymphocytosis, I think it's quite helpful if you find it. The question is, in what situations do you find it? And if you've got somebody with a CT scan that looks like IPF, either UIP or probable UIP, or a similar pattern, but potentially with a little bit of superimposed stuff that suggests a little bit of more uncertainty about the diagnosis. Question is whether it's helpful in that situation. And I think it depends on what population you're talking about as to whether you should be recommending it or not. And I suspect that some of the differences in the guidelines reflect differences in how the different committees approach the population of interest. So I think that's one of the major questions. At the end of the day, we don't have fantastic evidence that can convince a skeptic. And I think that's why we see that geographic variability or center to center variability, because there really isn't a definitive study that you can look at and convince a skeptic about. So I think it does still matter to some extent where you trained and whether you've had some of those anecdotal experiences where it really has been helpful. And there certainly are those anecdotes that do happen.
Yeah, Kerri Johannson already alluded to that in her presentation in terms of the threshold of 30% and 40% and such. So the guideline committee participants really struggled hard and came up with a consensus 30% would be a reasonably good cutoff to pay attention to. So Kerri, do you have any more words of wisdom on this?
Yeah, I think so. I think it does really, there's a cultural component to it, and I think there's a health system component. In general, historically, I think in American centers, surgical lung biopsy was done much more commonly than compared to other centers elsewhere. And that in Europe and in Asia, bronchoscopy was just done more because it's less invasive and it's a non-surgical procedure that's relatively safe. But when you really look at BAL, so if you actually look at how bronchoscopy is processed at your site and start to take it from the technique in the bronchoscopy suite, like whether you're throwing out like the sort of protocol or standard operating procedure of the bronchoscopy. Are you discarding the first 50 mils? How are you processing it once it's sent to the lab? Doing centrifugation with cytospin versus using other staining techniques. There's so much variability in the results that you're going to get. And so I think there hasn't necessarily been a standardized approach from center to center. And so I think it introduces a lot of variability. So what the CHEST guideline, I think, really gets at is that this is an ancillary finding. If you suspect the patient has HP, don't do a bronchoscopy to confirm that. But if you're unclear and there's a high lymphocytosis, that all goes along this Bayesian approach to what your pretest probability was to your post-test probability. So it's not, the absence of it doesn't rule it out. The presence of it doesn't mean it's only HP. It could be NSIP or organizing pneumonia, but really fitting it into the overall clinical picture. But it's a very complicated procedure, and I think we all just assume it's done properly and the same from center to center, which it's really not.
So one last question about the HP guideline. The question really is an appropriate one. Which HP guideline should the clinician use? On one hand, there are two guidelines, and so we complement each other, societies. But for the clinician, what do you suggest?
That's tricky. I think they both have different roles. I was actually on both of them, so it was a real luxury to be able to be a part of them and to see how they were developed. I think the ACCP guideline is a very practical clinical application. I think many people, and it depends on sort of the degree of confidence or possibly the prevalence of HP where you're practicing. But if somebody has a clear exposure and a definitive CT, I think many of us would say that's HP, and we would be happy to stop there. I think from a day-to-day clinical practice perspective might be different than how we're going to categorize this for enrolling patients in clinical trials to better understand this moving forward. But then bringing it back to that study, if we're happy with a 70% confidence, both of them perform very well for 70% confidence or higher. So I think to keep things reasonable for our patients, to minimize harm and maximize, general common sense, I think we can use both of them.
Okay, thanks, Kerri. So Chris, in a patient with probable UIP of unclear cause, do you ever consider a trial of corticosteroids to determine steroid responsiveness and subsequent justification for future immunosuppression?
Yeah, that's a great question and something that I think we often struggle with. And if you have somebody with a CT scan that doesn't have a lot of ground glass and you're leaning towards that being IPF, I think the most relevant data comes from the Panther study, where we saw in the first few months of that study, when patients were given that steroid at a slightly higher dose, those patients did very poorly. And that happened in the first 12 weeks or so of the Panther study when people were given usually around 0.5 milligrams per kilogram per day of steroid. And we saw an 800% increase in mortality, increase in the risk of hospitalizations, and just not a good situation in patients who had IPF. So if you're leaning towards IPF being the leading diagnosis or even a possible diagnosis with a reasonable percentage likelihood, then that trial of steroids is actually a trial of whether that patient is going to be harmed. And that's obviously not something that we want to do. So I think when you think of it that way, that trial of steroids can actually be much more harmful than helpful in that situation. So I'd be very careful about it unless there's significant evidence of an inflammatory component that would lead you away from a diagnosis of IPF.
Yeah, thanks, Chris. Another question for you is, do you prefer surgical lung biopsy or transportal cryobiopsy for the diagnosis of fibrotic ILD?
Yeah, it's a great question. Interested in what Tam has to say about this as well, but in my center, we're not doing cryobiopsies yet, so I don't have a choice. I think there are clearly some patients where I would like to have access to cryobiopsy, where for patient safety reasons, we can't do a surgical lung biopsy. So I think there's definitely a role for it. The Corte study was very illuminating that cryobiopsy can be a viable procedure in place of surgical lung biopsy, but there are also a lot of other studies out there that show that it can actually be a misleading procedure. So I think it's really important that if you're going to be doing cryobiopsies, that you're doing it very carefully and trying to replicate what the Corte study did, rather than some of the other studies that had greater difficulty with it.
Yeah, I think the preference really depends upon the expertise as well as the experience in the sites and centers to be advocating which procedure and then use the best clinical judgment, I would think.
Absolutely.
So other question for Tamera Corte in terms of the connective tissue disease. The role of nail fold capillaroscopy is an interesting one. Do you think it will be an important screening tool for connective tissue disease in the ILD patient group?
Yeah, I think there's increasing data for nail fold capillaroscopy in this group. I mean, but and in terms of screening, I think probably not screening, but I definitely think there is an increasing role for using nail fold capillaroscopy in those really difficult patients where, for example, they might be otherwise idiopathic with no clinical features, but they might have positive serology, for example. So, I mean, I think that the data needs to be there, but my suspicion is that there'd be an increasing role for nail fold capillaroscopy for in ILD clinics or ILD situations, particularly as it becomes more easier with the smartphone applications and to be able to done on site in the clinic. So I think it's a really interesting space to watch.
Yeah, another question that has been asked in terms of therapeutic interventions, is it enough to do HRCT twice a year during the therapy by antifibrotic nintedanib? The question is a good one, but I don't think we have addressed, I'm going to address this. I don't think we as the guideline committee or anybody has addressed the role of HRCT at a longitudinal follow-up. Twice a year appears to be too frequent, but we use clinical judgment in terms of the deterioration along with the other clinical variables, such as the conventional lung function testing and symptoms and such. So at least in our center and most centers, and the guidelines do not have any recommendation to say HRCT should or could or possibly need to be done twice a year. That seems to be a little bit too much. So Chris, what do you think?
Yeah, I would say that there are two main reasons for us to do a CT scan. Well, maybe three main reasons. One is during an acute episode of worsening to figure out what's going on, in which case you might also add contrast and look for pulmonary embolism. The other two situations are more chronic, and one would be to look for lung cancer. And there's probably a bit of rationale to screen for lung cancer every so often. Particularly if patients have other symptoms that are unexplained, such as weight loss or some other constitutional symptoms. Using CT scan to monitor patients is, I think, probably overused. So I would advocate for not using CTs on a routine basis to monitor for disease progression if other signs are pointing to that patient being stable. So in somebody with stable symptoms, stable pulmonary function tests, I don't think we need to do a CT scan unless you have some other reason for doing that CT. Yeah. So in my practice, that ends up being once every year or two, I'll do a CT scan.
Yeah, thanks very much, Chris. For the question that a physician has asked, I have a patient with biopsy-confirmed HP after COVID-19 pneumonia. No other exposure. Are you or others seeing much HP after COVID-19 pneumonia? It's an interesting question that this particular patient of the physician encountered with, having HP after COVID-19. I think the answer to that would be like addressing any other patient with HP. So you would go back to the patient and say what is in the environment that was different for the patient of COVID-19 pneumonia to have manifested granulomatous HP. So at least COVID-19 pneumonia patients are not subjected to surgical lung biopsy. The radiological patterns after COVID-19 pneumonia is evolving in radiology literature. Most of them have interstitial lung abnormalities. Some of them have organizing pneumonia, and a very few patients at about 6 months have a fibrosis pattern. Just a paper is online now in radiology from China about 6-month follow-up on COVID-19 pneumonia, that there's a good, believe it or not, at least in the radiology literature, but 25 to 30% of patients have fibrosis radiological pattern, but not so much in terms of HP pattern. So these are all the moving target and evolutionary knowledge that we need to wait and see. But coming back to that question of HP, so it looks like that patient with COVID-19 pneumonia must have had some other reason to have had HP, unless there were some of the drugs associated with HP. The other question.
I would think that they'd developed HP, and then to not infect their family, they were sent down to live in the moldy basement or some sort of indirect exposure that's more of a coincidental. I haven't seen any of that post COVID-19, although we haven't had that.
Yeah, so we have another 5 more minutes left for taking a few more questions quickly. So one of the interesting questions that has come is, have you been incorporating telomere length testing in fibrotic HP evaluation to decide between immunosuppression versus anti-fibrotic therapy? The answer to this question is based on some data. Obviously, that Chad Newton and others and Christine Garcia had published along with me in a retrospective data that, at least coming from the Panther patient population, that the telomere shortening is associated with more harmful effects that may be. But we are not routinely advocating that it needs to be done. But this is another research question that needs to be addressed. So we're not addressing routinely to do telomere and then deciding the immunosuppression. Obviously, telomere shortening and TERT and TERT mutation is associated with bone marrow suppression, and prednisone mycophenolate have suppression. And so that's an important thing that needs to be followed over time. So moving along, so a couple more questions. With regard to systemic sclerosis associated ILD, could you outline your approach to treatment? Basically, which medications do you use first line? When do you introduce antifibrotic or tocilizumab, for example? So Tamera, can you take this?
Yeah, well, I think that really does depend on the availability in your different countries. So I can outline my response, but I'd like to hear from yourself and from the Canadians on the panel, because I'm sure it will differ depending on availability. But certainly my approach would be to, if someone has deteriorating disease with systemic sclerosis and ILD, because I want to make the point that not everyone with systemic sclerosis ILD does need intervention or treatment, then I would consider usually low-dose steroids and mycophenolate. And then if someone progresses despite this, then I would consider tocilizumab or antifibrotics. However, I make a note that they're both very difficult to access right now in Australia. For systemic sclerosis associated ILD, although we will be able to access antifibrotics in the new year. So my approach is partly driven by the literature, but partly also driven by availability.
So now, in the same token, now that we have access to antifibrotic agents, do you think that there is less important to make a diagnosis of CTD-ILD and just give antifibrosis for progressive
I can answer that quickly. No.
Okay.
I think it's very important.
So the concept of IPF, do you think is outdated, or is it still a research question?
I think it remains a research question, definitely. I mean, I think it's probably less important to sort of argue about the sort of the underlying diagnosis in those really difficult people. But in terms of the importance of making a diagnosis of connective tissue disease ILD, I still maintain that that's super important.
So one other question. What is the treatment of acute exacerbation of IPF other than pulse steroids?
We desperately need clinical trials. We need a platform trial program set up to study this. We're all doing the same thing. Steroids, antibiotics, Lasix, oxygen, time, and prayer. And,
unfortunately, that is true because there's no data, but other than a knee-jerk pull steroids, at least that's all we are doing at the moment. So one last question, and then we're done because of the time. Patient with combined post-COVID fibrosis combined with CTD, any role of anakinra? So
I don't know. That's my answer. I'm really sorry. I have no experience.
There is no data to support that, but this is an important question that we'll need to wait and see how post-COVID fibrosis is going to pan out, whether in the presence of connective tissue disease or not. So with that, I think we're coming to a closure. We are coming to the time. So I don't think that there is any other burning question that I skimmed through unless you guys did. There is one question about association of hypothyroidism and interstitial lung disease. There is some data or older literature that I gathered from Chris and others. There is, but I don't know any data to say that is relative high association and incidence of mortality in such patients. So I guess the screening for that is not routine, but use your clinical judgment in terms for hypothyroidism. So that said, I think we came to the end, and thank you very much for all the participants who attended. And thanks very much for Chris Ryerson and Kerri and Tamera for joining. And I thank for the PFF Summit for organizing this, as well as the Medscape producers and all of that to help us out navigate through the virtual meeting. Thank you very much. Have a good rest of the afternoon and rest of the meeting. Bye-bye.